welcome to all the invisible participants who I'm sure will be watching and listening to this session and be as fascinated as I am. So the session is Behaviour Change in Paediatric Speech and Language Therapy. And as I say, I'm Christina McKean. I'm from Newcastle University and I'll be chairing the session. If possible, if you could put any questions that you have for our presenters in the Q&A section of the chat so that I can pull those out at the end of the session, that would be really helpful. We're going to complete all three presentations first and then have a discussion at the end of the session. So without further ado, let's give the time to our wonderful speakers, and I'm going to hand over to our first speaker, Dr. Jenna Charlton from Newcastle, who's going to be talking to us about UK paediatric speech and language therapists' perceptions on the use of telehealth in current and future clinical practice. Off you go, Jenna.
Thank you. Okay. I'm just sharing now. Let me know when you see everything.
Perfect. We're all good.
Yeah. Thank you. Brilliant. Yes. Yes. Thank you. Hello. Thank you to everyone who's joined this session this morning. My name is Dr. Jenna Charlton. I'm a research associate at Newcastle University working in speech and language sciences. I'm going to present a piece of work this morning that was led by the late and great Professor James Law, and involves some collaboration with other university colleagues from Newcastle, colleagues from the University of Cambridge, and colleagues at the RCSLT. And this work explored what UK paediatric speech and language therapists perceived about the use of telehealth in their own current and future clinical practice. And to do this, we applied the APEASE criteria. So a bit of background to start us off. So as we all know, the COVID-19 pandemic led to an increased use in telehealth as a primary mode of service delivery for many therapists. So we began this project by exploring what the literature published pre-COVID-19 told us about the use of telehealth in speech and language therapy. We found that many studies were small-scale experimental studies that focused on children with particular disorders, and we felt that the realities of at-scale clinical practice were not well represented in the literature pre-COVID-19, and many critical elements of service, such as client satisfaction and cost effectiveness, whilst often mentioned in the adult literature, was often overlooked in the paediatric literature. There was also little evidence informing what the long-term telehealth use might look like in clinical practice. So we use the APEASE criteria, which is an adjunct to the COMBI model of behaviour change, as a model to gather the perspectives of SLTs about their own use of telehealth during the COVID-19 lockdowns. And the APEASE criteria might be used to consider the implementation of approaches in real-world context, and it has 6 components. So it considers the acceptability of approaches to stakeholders. It considers the practicability of implementing new approaches at scale, the effectiveness of approaches for target groups, the affordability of the approach to stakeholders, the side effects, so both positive and negative side effects of new approaches, and finally, equity of approaches to different population groups. So the model suggests that each of these 6 components must be met for an approach to demonstrate successful effects and implementation. And by approach, in this context, of course, we're talking about the use of telehealth. So we use the APEASE criteria to structure an online survey for SLTs. And we had 2 main aims. So one, to identify key factors for optimizing speech and language therapy, and to make some recommendations for future service delivery, policy and research based on SLT perspectives. The survey was distributed by the Royal College over the summer after the 2 lockdown periods of COVID-19. And it included a background section where we asked respondents a little bit about their role. And then it had 6 sections covering each of the APEAS criteria, and a final open question exploring factors that SLTs might consider as being important for developing future telehealth services. To analyse the data, well, the APEAS criteria questions were analysed descriptively. These were mainly Likert scale questions. And our open question was analysed using reflexive thematic analysis, which included the use of both deductive and inductive reasoning techniques. Our results, so we had 438 UK paediatric SLTs complete our survey, but not all of those completed the open question at the end about future development of telehealth. But we did find that our sample was on the whole representative of the wider workforce of SLTs in the UK. So the majority of respondents worked within the NHS with primary school age children who had a range of disorders and disabilities. Our results were for acceptability. Telehealth was perceived as a more acceptable method for speech and language therapy intervention than assessment, which was viewed as more nuanced in terms of acceptability and level of agreement there. Considering the practicability of telehealth, well, the SLTs mainly agreed that yes, technology was easy to use, although some didn't find it easy to use, and a small proportion were unsure about this. We asked whether they were able to explain their clinical aims and instructions and discuss their challenges and barriers that some clients may face using telehealth. And for the most part, there was very strong agreement here that yes, SLTs felt they were able to do both of these things via telehealth. As for effectiveness, we asked respondents to consider whether they thought assessment and intervention delivered using telehealth was as effective as face-to-face delivery. Regarding assessment, respondents were relatively evenly split here in agreement and disagreement. So again, a little bit more nuance here. In comparison, proportionately more respondents were positive about the effectiveness of intervention via telehealth. We then went on to ask them which factors they thought played a key role in the effectiveness of speech and language therapy intervention via telehealth. And whilst parental assistance and access to the internet came out quite highly here, it's clear to see that there are a range of factors that SLTs think can impact the effectiveness. So where there's another category here, some SLTs also noted that the type of therapy required had an impact on how effective it was. So for example, consultative or strategy-based sessions, they felt required either a fewer number of sessions or the same number of sessions, but for assessment via telehealth, they felt that often more sessions were required. So again, there's a distinction there between assessment and intervention via telehealth. We asked about the affordability for clients. So we asked, did their clients have ready access to the resources and the technology in their home needed to engage in telehealth? And interestingly here, there was a relatively even split between the yes and the no. So for those who responded no, we asked them why. And there was a range of factors here that were identified as being important, including affordability, digital literacy, and internet access and speed. But 26 participants also qualified what they meant when they selected other factors here. And the most common reasons they gave were that families, some families had a lack of toys in the home that could be used in therapy sessions. And some families were required to share their technology with other family members at the time there was homeschooling happening, so that impacted access to appropriate technology as well. We then considered the affordability for SLTs, and we asked them whether they thought telehealth was more or less expensive than face-to-face interventions. And most respondents perceived it as being less expensive, but a small number of respondents did mention that there were some uneven cost distributions, i.e. between the therapist and the parent. And there were some contrasts between costs. So for example, where there may have been cost savings in terms of less travel costs, there may have been increased costs in terms of if failed appointments increased time costs of the SLT. And also client locations. So for example, if clients live in rural areas, SLTs perceive that some may have less access to appropriate technology or internet access, despite making a saving on their travel costs to attend appointments. So for side effects and safety, we asked, have you noticed any positive or negative consequences of telehealth? And the majority of respondents said yes, they had. The most common positive consequences reported were those that impacted parents, and these included things like increased service engagement from parents and improved quality of rapport. But the most common negative consequences reported were those that impacted either the therapist themselves, including screen fatigue and increased workload, or the child, so difficulties with maintaining children's concentration levels during their telehealth sessions. The final area of appease was equity. So we were interested here in whether telehealth improved the attendance of clients who had historically poor face-to-face attendance at sessions. And here there was a high degree of uncertainty between SLTs. And in a very similar vein, they were also unsure as to whether telehealth improved the attendance of clients who lived in more geographically remote areas. So there is a need to explore equity to different demographic groups a little more. I think there was a lot of uncertainty around equity. At the time of this survey, which was immediately post the COVID-19 lockdowns, respondents felt that despite a return to face-to-face engagement, that some telehealth would remain, and that for both assessment and intervention, the most likely approach would be mostly face-to-face with a little bit of telehealth. We then asked them our final open question, which was, which 3 factors do you believe are most important for developing telehealth services in the future? And from the respondents' answers, we were able to use inductive reasoning to identify 6 overarching themes. And in our paper, we actually unpack each of these themes a little more using the appease criteria. So firstly, SLTs believed there was a need for balanced and tailored services where telehealth complements rather than replaces face-to-face service delivery. They thought there was a need to address the technology and equipment needs of both the SLTs, themselves, as well as their clients. For example, there was uncertainty about how features of different platforms may impact quality and ease of use of families and allow for that interactivity that's required during sessions. Thirdly, they would like to see very clear information and communication about telehealth developed for themselves as well as for their clients. They believed there was a need to build capacity by increasing the digital literacy skills and confidence of SLT. So they recognized themselves that they weren't always as literate digitally to use telehealth with parents, and they would welcome some further training on this and recognize the need in parents as well. Monitoring and evaluation came out as very strong, so they would like to see monitoring of the use of telehealth and keeping up to date with the evidence base was seen as important to inform telehealth development and implementation long term. And also they would like to see clear leadership and governance, so to oversee any transition into embedding and implementing using telehealth as part of future service delivery models. To conclude, on the whole, telehealth was broadly acceptable and practicable to UK paediatric SLTs, but they did stress that telehealth should be reflective, tailored and flexible to meet the requirements and circumstances of not only the clients that they engage with, but them themselves as therapists. So considering the physical and emotional needs of practitioners was viewed as important. There was 3 strong recommendations from SLTs that the service development, including telehealth, should be clearly communicated to all stakeholders, that those using telehealth should be supported through appropriate training, and they welcomed this, and that ongoing effectiveness should be monitored. There is some further research required to understand A, the effectiveness in comparison to face-to-face delivery, B, which children benefit more or less from telehealth, and finally, the equity of engagement from different population groups. But we did feel that the APEAS criteria does offer a unique opportunity to ensure that telehealth models are sustainable and can be used long term, to support coordinated leadership at both local, national and international levels, and to support the development of policy and clinical guidance for practitioners, and also for information for clients themselves.
That's brilliant. Thank you very much, Jenna. Thank you. I'll stop you there. There's lots of lovely examples coming through in the chat while Dr. Helen Stringer from Newcastle University gets her slides up. Just a reminder to please pop any questions, questions or comments in the Q&A tab ready for the end of the session, because some really lovely comments coming through about positive experiences of telehealth, and also linking it to dosage rather beautifully as well. Okay, so without further ado, I'll hand us over to, as I say, Dr. Helen Stringer from Newcastle University is going to talk to us about behaviour change wheel in action. Over to you, Helen.
Okay, hello. I'm going to talk about the Northumbria Healthcare Newcastle University Universal Targeted and Specialist, or the NUTS framework. We all like an acronym, don't we? And how we use behavioural science to develop sustained partnership working between speech and language therapists and educational settings. I've worked with my colleagues Di Nicholson and Dr. Kate Hope since the beginning of this project, which was over 10 years ago. So over 10 years ago, I was funded along with Kate and Di to deliver a knowledge transfer partnership project with a number of educational settings that were part of a large academy group which provided education for 3 to 19-year-olds. Following years of implementing short-term change in schools, with speech and language therapy programs being vulnerable to staff changes, the aim of this study was not only to increase school readiness of all the children going forward, but to future-proof SLT services against staff changes in educational settings that could undo and lay waste years of work. Many of you will recognise the effort spent and wasted as programmes get lost in cupboards, or a series of supply teachers means that the implementation ceases. Over 6 campuses, we delivered a universal, targeted and specialist speech and language therapy intervention. We worked with 369 children, and we assessed their receptive and expressive language, speech, phonological awareness and educational progress on 6 occasions over a 2-year period. We have thousands of data points for this group. The universal intervention was an enriched language environment led by the class teachers. The targeted intervention was phonological awareness and sentence structure delivered by specially trained teaching assistants. And the specialist was whatever the children required from a speech and language therapist, supported by the specially trained teaching assistants. In an area of serious deprivation, all of the children benefited, with the more severely affected benefiting most. The detail of the pathways and the outcomes for the children we're reporting elsewhere. So we trained early years practitioners, teachers, teaching assistants, educational leaders, and speech and language therapists, facilitating a knowledge exchange. The SLTs trained the education staff and the education staff trained the SLTs. SLTs were additionally trained in social capital, which was very important. Over 10 years later, with a different academy organisational structure now in place, the settings involved are still implementing the universal targeted and specialist interventions. This work has become normalised for them, and SLT input is more efficient and streamlined. So what we learned here, number one, formed the background to the next 10 years. So we had some additional ESRC funding to investigate the key factors that led to the successful partnership working. We used the behaviour change wheel as our theoretical framework, and we put effort into these 3 levels. We used the behaviour change wheel to identify what was happening in the original KTP schools, to evaluate how the interventions were working on an organisational level. We assessed the children, but as I've said, we're going to report that separately. And we designed a framework that could be used in other organisations to replicate the process and make sustained, i.e. normalised change. We used the COM-B model, the capability, opportunity, motivation, behaviour, to help us make sense of situations and formulate actions. And we used it to structure our work into the SLT service and into the settings. So these are the 3 steps that combine to provide a robust pathway to behaviour change. Firstly, understanding the behaviour and identifying what needed to change, and then identifying the intervention options. So not SLT interventions here, but behavioural interventions, which will enact the sustained change. And finally, identifying the content and steps that needed to be in place for the change to occur. It was quite a change to be planning an intervention that wasn't actually about speech or language. We went through each of these steps at all stages, doing preparatory work as a team before talking to education setting staff, and including senior managers, teachers, teaching assistants, speech and language therapists at all levels in the organisation, and speech and language therapy assistants, getting their views on the behaviour systems and ideas about how to move forward. So in the next few slides, I've chosen different target behaviours to illustrate the things we learned. In reality, we went through this process examining each target behaviour in the same way. We've got over 100 pages of documentation containing information from our interviews or surveys. So what we learned, number 2, is that behaviours are part of a system. They don't occur in isolation. So talking to a class teacher to implement an intervention or adopt a change in practice will last while that teacher is in that class and has that child. When they move on, the intervention ceases and there's no one to pick it up. The best you can hope for is that the class teacher uses it in their new classroom. But if you get the senior leaders and the teaching assistants on board, i.e. either end, so to speak, of the setting, it can be sustained, so that not only do children benefit today, but future children benefit. In order to understand how the partners interacted and the interventions were implemented, we had to understand the whole system. And to do that, we considered the behaviours that interacted with, enabled, or were barriers to the target behaviour. This example is at the universal level of intervention. So to give you an idea about what the target behaviours are, here in these selected target behaviours for early years practitioners, they were apply knowledge of language development and delay, ask advice of speech and language therapists, so interact with the speech and language therapist, discuss with other staff in their own setting, and attend the training. And that included everyone in the educational setting all the way through. So what we learned, number 3, was about describing the detail of the behaviour. When considering sustained organisational change, both partners' behaviour should be described in detail in terms of who needs to perform the behaviour, what needs to be done differently, when will they do it, where will they do it, and how often will they do it, and with whom will they do it. So when enacting change, it should be recognised that one individual or organisation is not changing the other, but both change to accommodate each other and support each other in enacting the change, the behaviour that we're targeting. So what we learned, number 4, We use the COM-B model to structure a whole series of interviews and discussions with speech and language therapists and the education staff. Altogether, we had 10 COM-B models with a different behaviour goal in each one and different content in the boxes. It was then easy to see where change was needed and where existing good practice should be identified overtly and encouraged. One theme that emerged and was reflected in all 10 models will not be a surprise to anyone: protected time in which to implement the intervention, plan sessions and talk to each other. This was easy to address at source, although over the 10 years it has proved harder to sustain, and you can imagine what happened during the pandemic. So what we learned, number 5, was that we surveyed both staff groups to ask them what training they needed in relation to the target behaviours. We were able to identify specific training needs so that the training targeted at both staff groups would meet their needs, reinforce and not replicate what they already knew, thereby making it easier to incorporate into their everyday practice. SLT's knowledge of educational structures, constraints and drivers aided them in their interactions with the settings, and education staff saw language more holistically and understood the place of comprehension as well as expression. They were starting to talk the same language. So what we learned, number 6, is that audit is a good starting point. We developed an audit tool based on the COM-B model. It takes an average of 9 to complete both the audit and the action plan, and the audit is completed by a senior speech and language therapist, the head teacher and one other member of staff, over a conversation about the school organisation. It will provide an opportunity to evaluate the current capability, opportunity and motivation of the setting. This information can then be used to develop an individualised action plan to meet the setting's needs and priorities. The speech and language therapy service provided by NHS speech and language therapists is free at the point of contact. It's therefore in the interest of the educational setting to support the SLTs in maximising efficiency and effectiveness. There are additional services for children with SLCN that schools can buy in according to their need. Information from this audit may also be used in the settings Ofsted report as evidence of partnership working, adaptation of curriculum to meet the needs of the students. In addition, completion of the audit will provide an opportunity for a two-way dialogue to achieve a common understanding and agreement of joint priorities to meet the needs of children with SLCN. And what we learned, number 7, was only put one thing at a time in the action plan, because then the schools can achieve it. If you put 3 things in, they think, oh, can't do that. And none of it gets done. But if you put in one at a time, they can achieve it and you can go back and add more. So we learned that from working with these particular schools. So what we learned, number 8, was that the behaviour change wheel advocates starting with the open doors. So using existing knowledge of educational settings, we went for the quick wins, which makes the project more time efficient. And you build a reputation of effectiveness and word spreads around the more reluctant settings. So both sides benefit from the mutual learning, but it will explicitly help the SLT service with the harder settings. And what we learned, number 9, was that it's really important to have clearly defined roles and responsibilities for both partners and know at each point who's responsible for taking it forward. So things get done in a timely way and the work doesn't fall by the wayside if a member of staff leaves. Instead, it's passed on because the leadership team are motivated. We developed a manualised NUTS framework that can be used in educational settings to normalise partnership working. And what we learned, number 10, following a behaviour change model of investigation, focused our attention to both sides of the partnership, analysing a number of behaviours and choosing those that would have greatest impact with the least effort led to initial success that fed into increased motivation, enabling introduction of harder goals. An investment of SLT time at the beginning of the partnership supported the educational settings to adopt new ways of working that required less SLT supervision while maintaining positive outcomes for the children. So thank you very much for listening, and that's me.
Thank you, Helen. That was incredibly efficient and on the nose time-wise, as well as explaining something extremely complex, but also hugely practical and important. So thank you very much, Helen. Look forward to seeing some questions there in the chat, please, in the Q&As. So we'll now hand over to Marion Rutherford and Izzy Utley, who are going to be talking to us about evaluation of a national programme of change towards neuroaffirming practice in health and education in Scotland, which I'm really looking forward to listening to. We currently can see your notes and your slides, so if you want to see if you can change that to the full slide presentation, that would be great. I'm sure if you just go into slideshow mode, that will be fine. We'll give it another try. If we need any help, give me a shout. How are we doing? Is it you that's sharing, or is it Izzy that's sharing?
Yeah, I am trying to share. It's just I'm not quite sure why the notes are coming up.
Do you want to just try it again and we can have a look, and then we might be able to troubleshoot it? Yeah.
Is that any better?
If you just put slideshow on now from the beginning, I think we'll probably...
Yeah, I've done that. It is slideshow on my screen, so...
Okay, so I think what you must be doing is sharing the screen rather than sharing the window. So
let me have a look. Hang on.
Okay, I'll just send a message to Pete, because I believe he
thank you.
May have all of your slides on file, so I might be able to share them for you.
Can you? I can't. Sorry. Every time I go into it, it's the way that we practice. But every time I go into it, it won't.
Okay, I've sent a message to Pete. Maybe while we wait for Pete to come back to us. Yeah, we've got tick presenter view, as somebody suggested. But I wonder if we maybe take a question or two, if you want to. For Jenna and for Helen. Would you like to try while we do this, Izzy?
Yeah.
Getting rid of presenter view, or
I don't quite know how to get rid of. How do I get rid of presenter view? Sorry.
Do you want to share screen again, and we can try talking you through it?
Yeah. So I'm sharing the window.
Yeah, if you so can you say it says resolution, show presentation on, use presenter view in the top bar. Try ticking.
Yeah. Use presenter view. Let's try. Is that any better?
No.
Do you want to just make the slide as big as possible, Izzy, on your screen? Just in all the slides, and we'll just do it like that.
Yeah, let's do that. Okay, so yeah, make it as large as possible, and hopefully I think we can all see that, so that's great. And then move through the slides on the side. So I'll hand over to you. That's perfect. Thank you. I'll hand over to you then, Marion. I guess you're kicking off. Yeah.
Yeah, thanks very much. So yeah, welcome to this presentation with the perhaps not so catchy title, the evaluation of a national programme of change towards neuroaffirming practice in health and education in Scotland. We hope that we can provide a helpful summary of our National Autism Implementation Team, or NATE, Quality Improvement Programme, how it was planned, delivered and received over 4 years, and with an analysis of the active ingredients of this complex intervention. So Yep. I'm Marion Rutherford, and I co-lead the NATE team with a number of colleagues. We're funded by Scottish Government to support practitioners with the implementation of the changes that are needed for autistic and neurodivergent people across the lifespan. We're a multidisciplinary team, and it's speech and language therapists in the team who are here today. So myself, Izzy and Victoria. We're all clinicians and researchers, and although our career paths are not straightforward, I hope it's helpful for this audience, I guess, to see an example of how we're doing it. So as well as SLTs, our team includes my co-lead Lorna Johnston, who's a deputy head teacher. We have OTs, psychiatrists and researchers, and our team and our wider partners include neurodivergent and neurotypical people. And as far as possible, our programme of work is led by evidence informed by a wide range of voices of neurodivergent people. So here's a slide with our contact information. If you want to get in touch with us, this is how. Please feel free to follow us on @NATE Scotland, and the tools and resources and so on from the webinar and guidance that we talk about are available on our website. So this is what we'll cover in the session, and this is a QR code which links to our recent publication on the topic of the presentation, if you want to have a read of that, and we've tweeted that as well if people want to read that. So with speech and language therapists as key leaders in this work, it's included a multi-year, multi-phase national programme of training, practice development, education, dissemination and facilitation of change, with probably lots of overlaps with many of the things we've heard in the conference this morning, in the keynote or in this session. And it sounds grand, but it's obviously important to say that it's dependent on the participation of professionals and in everyday settings, and the participation of neurodivergent people and their families. So here's a bit of background to the study. So neurodivergent people, including autistic people, experience exclusion. They often wait too long for assessment and support, and they may receive inadequate support in education and health settings. So putting the neurodiversity paradigm and neuroaffirming approaches into practice is an evolving process, but there's work to do, and we're still all working, I think, to understand and embed these new ways of thinking. So at the core of a neuroaffirming approach is the involvement of autistic and neurodivergent people in the development of the research and in the NATE team. There's a need for a whole systems approach. Again, we've heard about this today, which is really exciting. And there's a huge amount of work going on all around the country, across the 4 nations, but capturing what this is and what works is complex, and I guess sending it in a way that makes sense to the people we're asking to support our ways of working as well. So to try and implement and then evaluate complex change, we drew on the Medical Research Council framework for developing and evaluating complex interventions and realist evaluation and analytic methods. So data and analytic procedures included a review of programme documents, consultation with programme leaders and consultation with professional stakeholders who've had a high degree of involvement with NATE activities and change over the past 4 years. So some of you might be interested in reading more about the Medical Research Council framework, which was recently updated, and here are a couple of articles that you might find useful. Complex intervention research goes beyond asking whether an intervention has achieved its intended outcome, but asking broader sets of questions. For example, not just asking, did it work, but how did it work? Complex intervention research is considered in terms of phases, and an essential phase during the early part of the work is defining the programme theory which underpins the intervention, which means that the intervention and the things that we're describing are reproducible, either as a whole or with elements within it. So realist evaluation is the method that we chose, and again, it's nice to hear that it's been mentioned already at the conference today. And the analysis we did led to the identification of a NATE programme theory expressed through a realist matrix of contexts, mechanisms and outcomes. A realist evaluation is a theory-led approach that seeks to understand what works, for whom, in what circumstances and in what contexts, and to think about all of those things in terms of what will make it more likely to succeed. So our experience of using this process, and in this and in other research, is that it's a really great method for speech and language or occupational therapy research, because we're not just thinking about who did what and what changed, but more broadly about the context affecting the intervention and the range of mechanisms which might be at play. It also helps us to think in new ways about what the outcomes are and to capture the intended and unintended outcomes. So what was our programme of work? So the aim of the study focused on identifying professional processes, activities and influencing factors, and didn't evaluate directly the effects of the intervention on neurodivergent people and their families at this point. So in terms of design, we performed a retrospective evaluation and collected data from a review of programme documents. We identified neat principles towards a neuroaffirming practice, and what are the key activities, resources and interventions that make up that programme. We consulted with programme leads and professional stakeholders, and a theory-based analysis was completed, drawn on the MRC framework and the realist analysis methods. We developed this programme theory and thought about how all of these context mechanisms and outcomes influence the NATE programme based on this comparison and synthesis of evidence. So a key focus was on identifying the factors that contributed to the successful implementation of NATE activities across different domains, including practitioner, institutional and macro levels. So there's more detail in the publication and on our website, but I hope we can give you a bit of flavour now about what we found and what were the active ingredients in the programme. So a key ingredient of the programme theory is expressed in key messages developed with neurodivergent people. For example, in schools, we refer to "we were expecting you" and the need for inclusive mindsets. Good things should just happen, and children shouldn't have to earn rewards to get things that other children just get. The environment first is a principle that crosses all ages. The match of the physical and social environment to the person is often the key to individuals being well regulated and participating meaningfully. And across work streams, we hold on to the belief that adjustments to the naturally occurring environments and just getting the basics right is actually often what's needed. Providing predictability is essential, and instead of asking kids to change, taking them out of school to do therapy for anxiety, or using approaches which potentially encourage masking, we can support them to feel well regulated by making the people and the things that happen more predictable. And there are others. We have overlapping and different key messages for adults, which start with "nothing about us without us," difference not deficit, environment first, diagnosis matters and language matters, and use a neurodevelopmental lens. So our intention with all of these is to have depth and breadth behind each one, but also to have a sense of what fits for each context. And including the General Teaching Council standards for meeting, start at the beginning. Part of our programme theory includes translating evidence in the form of practical guidance, so that we provide information, professional learning opportunities, and then national networks, so that it's not just providing the guide, but then we create opportunities for people to get together and meet and talk about the focus, a shared focus. And our aim is to be responsive and to develop guidance and professional learning opportunities which reflect the needs arising. So these are some of the materials here. So the General Teaching Council for Scotland standards for meeting the needs of autistic learners, children's neurodevelopmental pathway guidance, an anxiety-related absence guide, recommendations for neurodevelopmental pathways for assessment and diagnosis for children. And we've also led on work developing autism resources that are being delivered as part of all initial teacher education providers in Scotland, and from our work with autistic professionals, we're developing guidance for employers. So we know that simply making documents isn't enough, and that we have also to provide different ways for people to access and interact with the learning. So as I said, we run these professional networks. We have 3 currently: a child Neurodevelopmental Pathways Network, Adult Neurodevelopmental Network and a CERTS network to support and follow up on the implementation. So from our consultation, there was a strong message from practitioners that people are the key ingredient. So much of what makes this work is about seeing things from a range of perspectives, and it's the sense that the community could trust NATE as a source of information and support was really important. Although being perceived as competent leaders and knowledgeable in the field is important, a big factor is supporting and challenging, but within a no blame culture, and acknowledging that essentially people in the profession, our profession and the people we work with, want to do things right, and adjusting and thinking about changing practice can sometimes be hard. In the more formal analysis, we identified context factors. There's obviously lots on the page. I'll not go through all of these, you'll be glad to hear, but these are factors which favour or disfavour the activation of mechanisms. You can read about them more in the paper if you're interested, and I'm sure some of them resonate with your own experiences. There were 3 clusters of mechanisms identified under these headings of macro, practitioner and institutional mechanisms, and these are processes underpinning changes in outcomes or active ingredients of the NATE programme. So 2 mechanisms were at the macro level, and macro mechanisms capture the systems of government and policy which NATE's part of. These mechanisms were related to NATE's status as a government funded and endorsed programme, as well as liaison and communication with government and other national bodies. There were 7 practitioner mechanisms which relate to actions and characteristics of the team. And the realistic matrix at the institutional level included 4 mechanisms. These represent the processes which, when activated, support the outcomes at the other levels, for example, in schools or hospitals or other support settings. There were 17 outcome areas identified, which are linked to the context and mechanisms, and I'll try and summarise these here. The direct role of NATE is to support practice change, and like the concept of trauma-informed workforces, an outcome that we are working towards is a neuro-affirming workforce. So it's not just about having a neurodevelopmental service, but actually how we embed this as a societal and a service-wide approach. We can assume that an indirect impact on neurodivergent people happens, but multiple variables limit the possibility of evaluation of the extent and nature of the impact currently. Qualitative methods with neurodivergent people would provide useful descriptions of how they experience education, work and health settings after change is implemented. One example is a special school in our area who reduced their incident of reporting of violent incidents to 0 after implementing CERTS and changing mindsets across the school. So we need to try and capture some of these examples. I think there's lots of examples of great evidence that we don't necessarily write up and publish and share. Outcomes might also include other measures captured in services, particularly things like fidelity to principles and uptake of specific recommendations, which would also provide useful insights. Key longer-term outcomes for evaluation are development of whole system, multidisciplinary, inclusive services, reduced waits for assessments and supports. Competent, confident staff, and most importantly, improved life experience outcomes, which are not measured by neurotypical norms, but which are focused on outcomes which are important to neurodivergent people. And finally, one mechanism and outcome that we're very excited about is the new National Neuroaffirming Community of Practice in Scotland. We held our first event at the end of October, and I guess you can watch this space for developments as our collective knowledge and practice evolves, and it's, again, will be great to have connections across the 4 nations as there's so much happening in this space at the moment. Thank you very much.
That's wonderful. I wish I had lots of clapping emojis that I could put up for everybody. Thank you so much, everybody, for those really fascinating presentations. Could Helen and Jenna and Izzy, could I ask you to put your cameras back on so that we can have questions as well, question and answers? And thank you. People have been putting them in the Q&A, so that's really fantastic. Thank you. There's a theme that's coming through in some of these questions that I think probably Helen and, well, maybe everybody has a comment to make about this, but particularly Helen and Marion, I think. A question has come through about how do you make these changes sustainable within, and I think, Marion, you were beginning to speak to that very much at the end of your presentation. How do you make change in attitudes, behaviours, skills in the children's workforce stick when we have such massive churn and turnover in staff? Helen, would you like to go first, and then I'll come back to Marion maybe?
Okay, I think the key bit of that is that you embed whatever change it is in policy, so it's not just dependent on individual people. I think that's really important, so it becomes part of the ethos of the organisations. But also having things available for staff. So for instance, we've got some online training so that any new staff have that as part of their induction, and immediately they are sort of brainwashed into this way of thinking, but also they feel better. So actually, I think our staff turnover, we've got some staff, teaching assistants who've worked with us for over 10 years because they feel enormously valued and invested in. And I think that's a really important bit. It's changing the culture, really quite significantly in those organisations, in those schools, so that people want to stay. I know in some settings that's difficult because you've got a changing population, but actually getting that motivation and the buy-in, so going back to the COM-B model again, I think is really important.
Lovely. Thank you. Marion, would you like to add anything to that?
Yeah, I absolutely agree. I think having these things embedded in policy, or whether it's the school improvement plan or the local health board improvement plan, having these directions of travel and where we're going embedded is really important. I think one thing that we found is getting leaders together is really important to support them with the persistence. So for example, implementing certs, people go in the training, they love it, they think, yep, this is what we want to do, but actually in the real world it takes quite a bit of work, and the opportunities to meet other people who are doing the same, but also where people have kind of cracked it, giving them a forum to be able to share that, I think is also highly motivating. And then the last thing I would say is we need to include this way of thinking in our initial training. It's career-long professional learning, so how we find interdisciplinary ways of doing that, I think, is really important.
Brilliant. Thank you very much for that. You've used an example there that links to one of the questions here about examples of when you've cracked it, and somebody's asked in the Q&As, Helen, of any examples for some of these quick wins or open doors that you mentioned. Could you give people some sort of concrete examples of some changes that you were able to implement quite quickly?
So some of those were things like having specially trained teaching assistants, so who were named as speech and language therapy teaching assistants. Having ring-fenced time was the most important thing, but also having everyone involved, and that was also important. So just insisting that the head teachers came to the training and the SENCOs, the special needs coordinators came to the training was really, really important as well. So it was little things like that popped out of the audit that we used, and then the more complicated things that came along, like things like buying in extra speech and language therapy, but we now have a situation where our teaching assistants are consciously working towards the speech and language therapy goals and recording whether the children are achieving them or whether are on a pathway to them, and also alerting the speech and language therapist to when the goals need changing. So it's very, very embedded, and it started with just those little tiny things.
That's great, thank you. So Jenna, then thinking about maybe not so much quick wins, but in telehealth, a lot of the comments and the questions that are coming through are people saying it worked brilliantly for this and it worked less well for that. So I think, have you got any thoughts looking into the future from what you learned in the survey about what would be good ways of continuing to use telehealth? Did you get any insights on that?
I think, yeah, what came out really strongly for us is exactly that, is the conditionality of telehealth, and that it's not necessarily one size fits all. I think there is some guidance to be developed and at the system level, but also at the organisation level, so everyone's on board of what, you know, within in their team, what is their telehealth offer for clients. But then it's about individualising that offer to meet the needs and circumstances of the individual clients that they're working with. So we had a paper published previously in IGLCD, which used the COM-B model of behaviour change to think about the components necessary for implementing telehealth at the individual level for clients and for practitioners. But I think it's about teams being on board and clear what their offer is, but then also tailoring it to meet the needs and circumstances, because that came out really strongly that it sometimes works for that, it doesn't work for that, it works for that family, but not for that family. So it's about being flexible, I think, in their approach.
We've got some lovely comments of people sharing particular contexts that they feel it works really well. So, for example, adolescents with persisting speech sound disorder, there's some people thinking that seems to work very well and gets the dosage up when they wouldn't normally get that, and also bringing parents together without the need to travel to central locations. So it does look like there's still a future for telehealth, but maybe in a much more targeted way. So thank you everybody for sharing those, as well as the funny stories of parents wandering around in the background in their underwear occasionally, not realising they're on screen. So yeah, keep those comments coming. Marion, we've also got lots of people saying, oh my goodness, those resources look so beautiful and wonderful. Could you remind people where they can access them? I myself, I wrote down, oh my gosh, I want those beautiful developed messages that you've got about working in schools.
Yeah, absolutely. So they're on our NATE website. I'm not sure if the key messages for work in schools are quite on the website. We're developing a national resource for primary school staff around those key messages, and so that's they exist in different formats. The one for adults is there on the website. Izzy might be, yeah, Izzy's put the website.
Oh, thank you. That's
all of those documents that we highlighted, they're all there on our website.
Yeah, I wrote down that I really want those, love those key messages, and it shows the power of working with the people, you know, themselves in partnership, doesn't it? Those messages are so much more meaningful than because of that partnership working that you've done. Thank you. Helen, as well, we've got, where can we get the audit? People want to know where they can access the audit tool, and is there any information you can give us about that?
Yeah, in the new year, we're going to launch our website, and the NUTS manual and the audit and everything will be available there. So all the processes as well that you need to go through for different organisations. And if you Google, when you get there, if you Google NUTS Newcastle University, that should bring it up. Don't do that yet though, because the website's not up there. But also, you know, we'll be advertising it on, you know, around. So hopefully you'll all pick it up.
And lots of people have also asked for the slides. I'll check with the conference organisers. I would imagine they'll be asking all presenters whether or not they're happy to share slides, and I'm sure they'll be coming up at some point. Helen, do you know a bit more about that?
Yeah, the recordings are all available, and actually that's sort of better, I think. So if you just look on your agenda, when you get towards the bottom or at the bottom of a keynote speech, you can see there's links to all of the talks that we've had. And they're there almost immediately as well.
That's great. Okay, so I wish we could applaud like you can on others. I just wanted to say thank you for a really fantastic session. I'm sure everybody's learned a great deal, and I've really enjoyed it, and will be wanting to steal as many of these resources as I possibly can. So thank you very much, everybody, and enjoy your break, and I'll see people in future sessions. Thank you.